Good evening. This is Dr. John Bennett for Neurosurgical TV in Biratnagar, Nepal. Tonight we have another in the all about spine, and we have Victor Hugo Perez, MD, a noticed anatomist from Mexico, going to give a presentation. But first, let me introduce members of the panel. We'll start with you, Marco.
Hi, good morning. My name is Marco Antonio. I'm from Bolivia. Thank you.
Welcome, Marco. And Nick, are you there?
Yes, I'm here. And I'm very happy to see that Victor is in now, and I'm eager to see his presentation.
Okay, we have, I guess he can't come in. Ipe is in the background there. Okay, Victor, welcome, and it's all yours. Could you just talk a little bit about yourself, what you do, where you're at, etc., before you start your presentation, please?
Hello. Yeah.
Hello. How are you?
Yeah, it's good. Victor just got connected, and he's presenting now.
Okay, Victor, can you tell us a little bit about yourself, please?
Yes, thank you so much to this invitation to present the vascular anatomy of the spinal cord. It's very, very amazing to see the irrigation of this part of the human body. I have been working with this.
I will reinforce this statement in front of him as well, because I completely agree.
Yes. I have been doing this work since almost 8 years ago. So I have found several variants of the irrigation of the spinal cord that I want to show you. Can we start?
Yes, we can.
Okay. Let me... Okay, now... is it okay?
Yes, we can see it fine.
Yes? Okay.
Yes.
Okay. Okay. This is the lumbosacral segment of the posterior aspect of the spinal cord. Here we have the venous drainage of this segment of the spinal cord. What I have done is to inject latex in the veins and also the arteries in the spinal cord in order to see this irrigation. Albert Adamkiewicz was a very known pathologist and neurologist also from Poland. He lived from 1850 to 1921, and he is now very famous because he discovered this artery, Adamkiewicz artery. Adamkiewicz injected arteries and veins of the spinal cord, applying a special method by using Teichmann mass, which consisted of ammonia, zinc white, linseed oil, mercury sulfate, or carmine sediment for the red color of the arteries and Prussian blue for the veins. Now we use a very simple mix. We use silicone and then we put some color. We mix it and we can have a very nice material to inject the specimens. We need, of course, a specimen well fixed with formalin in order to make a good injection. In this picture, you can see the vertebral arteries. The right one is hypoplastic, and the left one is giving rise to the basilar artery. We can see also the anterior spinal artery coming from both vertebral arteries. The artery of Adamkiewicz traveled with the ventral root to the ventral surface of the spinal cord, where it took a characteristic hairpin turn caudally. This is the aspect of the Adamkiewicz artery. It has a characteristic hairpin form. The irrigation of the spinal cord is heavily dependent on the artery of Adamkiewicz and branches of the vertebral arteries. This artery is of enormous clinical, surgical, and radiological importance. Here we have the dorsal aspect of the cerebellum and the low brain stem and the upper cervical cord. We can see both vertebral arteries and the posterior nerve roots, superior nerve roots. Here we have the characteristic aspect of the Adamkiewicz artery. In the upper part, we have a small artery in the end. The preoperative localization of this artery is very important in the surgical transthoracic spine procedures. The anatomical knowledge gained preoperatively may reduce the risk of postoperative paraplegia. For example, in this spinal cord, you can see an unusual presentation of this Adamkiewicz artery. This artery is coming or is arising from thoracic tree level. It was the highest level that we found in 40 spinal cords studied in this research. In the superior imaging, you can see the middle of the spinal cord from cervical to thoracic, and in the inferior image, you can see the thoracic and also the lumbosacral segment. And the Adamkiewicz artery is coming from T3. This is a close image from Adamkiewicz artery coming from thoracic tree segment. I'm going to put the image some 5 to 6 seconds in order to see much better and appreciate the image. Here you can see the nerve roots, the Adamkiewicz artery arising from T3, and also the arachnoid membrana and the dentate ligament. This is the lowest level of the Adamkiewicz artery, arising from left lumbar 2 segment. This is a very nice picture and also very good preparation of the spinal cord, and the color of blue in veins, color red in arteries, and I like too much this image. I displaced the nerve roots, the artery, the vein, and here you can appreciate the lateral aspect of the spinal cord, the conus medullaris, the posterior spinal artery, giving some very small branches to the nerve roots. And in the lateral aspect of the spinal cord, we can see the anastomosis between veins and also arteries that are joining or communicating the anterior and posterior aspect of the spinal cord. In the inferior part, we can see the arterial basket of this Adamkiewicz artery. A drawing obtained from an original article by Adamkiewicz, published in 1881-1882, showing arterial vasculature of the spinal cord and the bidirectional flow of blood in spinal cord vasculature. Of course, these are very, very good drawing, but nowadays we can make good pictures with photos to the vasculature of the spinal cord. Here we are in the lowest part of the spinal cord, known as conus medullaris, and also very small branches coming from the posterior spinal artery. In the upper part, we can see the Adamkiewicz artery. A great anterior radiculomedullary artery, Adamkiewicz artery, is the name, another name of this complex artery. All the 40 spinal cords had Adamkiewicz artery. 36 from the left side, 11 from left T9, and 8 from left T8. Most of them are coming from T9. The average diameter of the artery of Adamkiewicz at the spinal cord was 0. meters, and with a range from 0.6 to 1.11 millimeters. In 4 spinal cords, this Adamkiewicz artery was in the right side, but 2 of these spinal cords was double. The Adamkiewicz artery arises from both sides. In these pictures, you can see the origin in the left and also in the right. This spinal cord has a very small anterior radicular artery in the lumbar segment, and the Adamkiewicz artery coming from the thoracic, could be T9, T10, the left side. This is a very small artery that is providing blood to this segment. This is the Adamkiewicz artery. What you can see in this picture is this artery. Always, this artery is giving rise to a very small artery that goes upward to join the thoracic segment. But in all the specimens, this artery is very small. This is another picture that shows this Adamkiewicz artery coming from left and also the right side. These are several pictures from this spinal cord. Let's go to see what happened with the thoracic arteries. This artery was present in 38 spinal cords from 40, 32 in the left side and 6 in the right side. 2 spinal cords did not have thoracic artery. Most frequent in left T4, 9 specimens, followed by left T3. 7 specimens. In 10 spinal cords, there were a double thoracic artery. In the left side, we have the thoracic artery arising from right side. And 2 thoracic arteries arising from left side. As you know, the thoracic segment of the spinal cord is smaller than the cervical and lumbosacral segments. So in this segment, the irrigation could seem to be very, very small, very fine, but it is the irrigation is according with the size of this thoracic segment of the spinal cord. This is a small thoracic artery. The narrowing of the thoracic segment of the anterior spinal artery has an average diameter of 0.33 and it is from 0.17 millimeters to 0.53 millimeters. This measure was done at thoracic 5 level. In all the 40 spinal cords, we took the measure of this thoracic artery always in the thoracic 5 level in order to see what is happening with the size of this thoracic artery. So the average diameter of the thoracic artery in this level in this study was 0.33 millimeters. The needle, as you can see in this picture, is in thoracic 5 segment. This is the thoracic artery. We found also the great posterior radiculomedullary artery. This artery is very interesting because it's not, until now, it's not well studied in some studies that have been published. This great posterior radiculomedullary artery was found in 28 spinal cords. This artery was found in the left side in 19 spinal cords. In 16 spinal cords was found in right side. In 7 spinal cords was found in both sides. The great posterior radiculomedullary artery. This is the great posterior radiculomedullary artery that is coming from left T10. This is a very, very nice picture. I want to tell you that this artery is not well studied until now. My focus of this research is this artery. Various authors postulate such a vessel. Gillian in 1958, Lasortes 1957, in 1962 Romanes, Jellinger in 1966. They postulate that this artery exists, but others do not mention it or even deny its existence, as Corbin in 1961, Clemens 1966, Jindian 1970, and Domis in 1980. As you can see, the main studies of this artery are from from 60s or 50s years. According to Jellinger, a large posterior radicular artery is seen caudally in about 75% of instances, but its caliber does not approach that of the large anterior vessels. Diameters from 350 and 500 micras. Its height is more caudal than that of the anterior radicularis magna artery. I can say now with this study that there is no doubt about its existence. The great posterior radiculomedullary artery is coming from left T9 in this picture. In this spinal cord, even when there is not a great posterior radiculomedullary artery, there is a very good anastomotic arc from the Adamkiewicz artery. Look at that anastomotic arc. It's amazing. It's beautiful to see this artery. These pictures are from this specimen. I'm going to repeat the images to look this anastomotic arc. This is the lateral aspect of the lumbosacral segment. You can see in this also the conus medullaris, the lateral aspect, and the ligamento terminalis. In this spinal cord, there was not a great posterior radiculomedullary artery. Instead, there were several radicular arteries. A left view of the anastomotic arc. Most of the arterial supply comes from the right side of the anastomotic arc. In relation with the cervical radiculomedullary arteries, there were 24 cervical arteries coming from the right side, 8 from C6 and 8 from C7. There were 11 cervical arteries coming from the left side, 4 from C5 and 3 from C7. These arteries are more difficult to inject because they are very, very small. In 4 cord spines, there were 4 cervical arteries. In 5 cord spines, there were 3 cervical arteries. In 8 cord spines, there were 2 cervical arteries. Cervical cord arteries. Its average diameter is 0.49 millimeters, from 0.21 millimeters to 0.73 millimeters. So you can imagine how to put a needle, a very small needle, inside these arteries to inject. It's very difficult, but it's possible to do that. This cervical artery was the smallest. As you can see, they are very, very small. We can see also the nerve roots, the cervical nerve roots, the dentate ligaments, the dura mater, and the arachnoid membrane. In 29 spinal cords, there were a great spinal anterior vein. This is respect to the venous drainage of the spinal cord. The average diameter was 0.8 millimeters from 0.46 to 1.32. This image is very, very nice. So let's go with the anterior slide and to see the great spinal anterior vein. Great anterior spinal vein. Great anterior spinal vein. If you have any question, you can ask if you have some doubt. Posterior veins, the great posterior spinal vein. In 32 spinal cords, there were a great spinal posterior vein. Average diameter 0.86 from 0.52 millimeters to 1.48 millimeters. The vein is more easy easier to inject. Posterior spinal vein, this was the biggest, 1.48 millimeters. It's really beautiful, these arteries. In some of them, this vein is complex, as you can see in this. The veins covered with the arachnoid membrane. I think that pictures speak by themselves. Anatomy is universal. So if somebody see this picture, we don't need some explication. Pictures speak by themselves. This was the smallest 0.58 millimeters of these veins, veined with some small curls. The form of this vein drainage is capricious than is more capricious than the arterial supply of the spinal cord. We can see several forms of this venous drainage. In this picture, you can see this vein crossing a nerve root. This vein passes between the nerve root.
Professor Victor Hugo.
Victor, you're muted,
You are
Victor. I
muted.
don't know if you realize that. Hello, Victor, you're muted. Hola, Victor. Tú estás mute. Tú estás mute, Victor. I can try to release it on this end.
Okay.
Okay, there we go.
Let me see what's happening.
No, está bien, Victor. Yeah, we can hear now. It's okay.
Okay.
Yeah, okay. You're off the screen share if you want.
Okay. Can you?
Yeah, it's great. Yeah, we see it. We see it.
Okay. Adamkiewicz also attempted to describe the Venus network, which was subsequently characterized as complex and difficult to interpret. He also noted the variable density of the microvasculature within the spinal cord. As you see, this is very complex. There are many variants. Do you hear me?
Yes, we do.
Okay. This is a curl in the posterior aspect of the spinal cord. It's beautiful. This kind of veins. Okay, I'm going to show you 2 videos about this. Let me show you first this one. Can you see it?
Not quite. It's only taken half the screen up.
Okay. Okay.
Yeah, just try, pull it to the side a little bit.
Okay, can you see it?
Yeah, we can see it.
Okay. This is a very complex form of the venous drainage. And it's not pathologic. It's not pathologic, this formation. It's only an unusual variant. John Bennett, I am hearing too much noise.
Okay, too much feedback.
Too much noise.
Okay. I think, Greg, you have 2 screens open there. You have to get out of one, I think. You're on 2 Hangouts. So let me try to. Yeah. Okay, there we go. Okay, how is it, Victor?
Better.
Okay.
Okay. So here we have the posterior aspect of the spinal cord. This is the arachnoid membrane covering the veins and arteries of the spinal cord. In the lumbosacral segment of the spinal cord is it's very easy to inject these veins. But in the thoracic and in the cervical segment, is very, very difficult. And the venous drainage predominate in the lumbosacral segment. This is the thoracic. This is the thoracic segment. In some spinal cords, they are very well injected, but in others is difficult. And as you can see, it's not easy to define the pattern of the venous system. Let me show you another video. Can you see this video?
Yes, very well.
Okay. Okay. Let me see. Let me see what happened with that video, because
Whoop, you fell off.
I think so. Yes, let me see what's happening with that video.
Okay.
Okay. Wait a minute, please. I don't know what happened, because okay, let me see what happened with that video. Okay, here we have.
Okay, yeah, looks good.
Okay. Wow, excuse me. Let me. Okay, can you see it?
Yes.
Okay. Okay. I think I lost the other one that I wanted to show you. I lost that video.
Okay.
But I think that's it with this presentation, John Bennett.
Okay, very good. Victor, thank you once again. One of your many excellent presentations. Great pictures. And I'll let the neurosurgeons comment. Welcome, Gregory.
Hello.
Do you want to comment to Victor on those beautiful drawings? Beautiful.
Yeah, I thought they were tremendous. Really nice to watch it.
Yeah. You know, Greg, Victor was saying that the spinal anatomy is kind of neglected compared to brain anatomy, and that he's hoping to rectify that. Right, Victor?
Yes.
Now, how long? Oh, go ahead. Go ahead.
No, I just wanted to say that it was a great presentation, and it was a very good anatomical specimens. I was about to ask you, do you have some, let's say, have you encountered any dural AV fistulas that you can show us, or maybe in another presentation, because that would be interesting.
Okay, I have injected almost 150 spinal cords, but until now I only have studied 50 spinal cords. In one of them, we identify a malformation, but I can tell you what kind of malformation, because we are studying this spinal cord. So I'm not sure until now what kind of malformation, but only one in 150 spinal cords.
Okay. Okay, that's great. That's great. So that's be interesting, obviously, to see, but it's not very often, so that's understandable.
Okay.
All right. Thank you, Victor. Thank you so much for that.
Thank you. Thank you very much for the invitation. It's a very great honor for me to participate in this conference.
Oh, Victor, it's a great honor for us to have you.
Thank you so much.
And welcome to Greg.
Thanks.
Hi, Greg.
Thanks for
How are you?
asking me. Good. Good.
John, we don't hear you.
John's muted.
Okay, I'm sorry. Victor, the injection, could you describe that? Is it a pretty arduous process to inject the veins with latex, right? That's where you use the material?
Yes. Well, I only use silicone with some diluent, but there is no special technique. I think the most difficult part of this study is to get the specimen, fresh specimen to inject it. If you don't have a good specimen, it's impossible to make a good injection of the spinal cord and also the brain. So the technique is not the most important part of this study. The most important thing is to have a good specimen.
When you say a fresh cadaver, how old cadaver are you talking about?
Well, in the Forensic Sciences Institute of Mexico City, you can make this study in corpse 3, 4, or 5 days after death. But as you know, they are under refrigeration, under freezing. So it doesn't matter about the time. The only thing is that the specimen is well preserved under freezing.
Oh, okay. Okay, so that's the important factor.
Yes.
Okay, Victor.
Okay.
Any other comments or questions from Nicholas, Greg, or Marco?
No, I'm. It's really nice to see you again, Greg.
Nice to see you, Victor.
Nice to see you too.
Keep up the good work, huh?
Thank you.
Very good, Victor. We'll end this and put this in your portfolio. And thanks everyone for coming out. We'll formally end this presentation and hang on for a presentation from Greg next. Okay, boom, that's it. Now we edit it and package it, Victor, and send you another notch on your portfolio.
Yes.
Okay, Greg, would you like to start right away?
Yeah, I can start. I'm just going to.
Okay. What you want to go over the screen sharing first before you start?
Yeah, I'm getting there.
Okay.
I should be on screen share.
Okay. Yeah, there is perfect. Let's see. Change the screen to make sure you can change it. Okay. Whoop! It went back to the.
I'm gonna do something different.
Okay.
I'm gonna do this.
Okay.
That view,
Yeah,
I'd rather.
yeah, that's excellent. That's excellent.
All right.
Okay, so you got it, huh?
Yep.
Okay, let me introduce you. Get off that, and let me introduce you, and then we'll go ahead.
All right. Well, I'm gonna leave it. I think it just.
You want to leave it on there and just go into.
Yeah, it might be hard to, because I have to stop screen sharing.
Okay.
I can do that. I can stop.
Okay.
Okay, it should be.
Okay, yeah, let me introduce you first, and then we'll go.
All right.
10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good evening. It's Dr. John Bennett broadcasting from Biratnagar, Nepal for Neurosurgical TV in cooperation with the ACNS. We have another in the series of All About Spine. Tonight, we have the pleasure of having Gregory Trost, a neurosurgeon from Madison, Wisconsin, giving a presentation of All About Balance. First, let me introduce the panel before we turn it over to Greg. Good evening, Victor. You're on mute there, Victor. Unmute there, Victor. There you go.
Good evening. Greetings from Mexico City. Nice to see you again.
Victor's a neuroanatomist, neurosurgeon from Mexico City. And Nikolai. Whoop, he may have stepped away. Marco?
No, it's here. It's here.
Oh, there you go.
Everybody. Yeah.
Okay.
Nice to have you, everybody. And so far I'm enjoying so much this, and it's good to see all these nice presentations and to be part of this. So Greg, thank you so much for being part of that as well, and welcome.
Great,
I'm keen to see your balance talk.
Okay.
There's a lot to it.
Nikolai's a neurosurgeon from Belfast. Marco.
Hi, good evening. My name is Marco Antonio. I'm from Bolivia. Thank you.
Very good. Okay, Greg, it's all yours.
All right. Let me screen share. Let me get this. How's that look, John?
Good, looks good.
Okay, good. So this is a talk that's sort of evolved over the past several years now, and illustrates the importance of considering balance as we start to talk about spine surgery and consider what we do in spine surgery. A lot of people say, "Well, I don't do deformity surgery." Well, I would propose that all spine surgeries are deformity operations. We're either causing it, fixing it, or preventing it. We also know that balance is a three-dimensional process, so it's not just sagittal plane or coronal plane. It revolves around all 6 degrees of freedom that we have in the spine. Remember also that balance is a global spine consideration. It's not just isolated to the thoracolumbar spine or to the cervical spine. In fact, I'll show relations between both of those areas of the spine that we've talked about. I also like to think that the balance really doesn't equal alignment. Someone once said that balance is alignment in motion. So they're used together, but they're often different concepts. Then we'll talk about things about clinical assessment, and I'm going to actually probably concentrate more on cervical deformity and global alignment rather than just thoracolumbar, but I will review the thoracolumbar parameters that we've talked about over the years. I'll talk about the cervical parameters, some corrective measures, and then I'll show a recent article talking about evolving considerations in treatment of deformity. So we know that thoracolumbar parameters and thoracolumbar balance and scoliosis or deformity have been relatively more understood or at least discussed. I think this is still an evolving field. What we have noticed, though, is the importance of the pelvic parameters that have become more widely discussed over the past 7 to 10 years. So just to remind us that the pelvis is essentially a complex structure and that its purpose is to transmit load from the spine and body down through the pelvis to the femoral heads down to the legs. And if you'll look at this, remember that the length of the pelvis is basically from the midpoint of the sacrum down to the femoral heads. This will be an important relationship to pay attention to, and this is one of the things that's used in discussing pelvic parameters. We should also note that the pelvis is relatively complex and actually quite variable. So there's two things that we have to take into account, and one is the orientation of the sacrum, which is independent of the pelvis length, and then the length of the pelvis, which is highly variable. We also need to correlate the thickness of the pelvis and the orientation of the sacrum. So this is just a summary slide of the pelvic parameters that have been talked about. And remember that this number, pelvic incidence, PI, which is measured from the femoral head to the midpoint of the sacrum, and then taken as an angle with the perpendicular to the superior end plate of the sacrum. This is pelvic incidence. This is a number that doesn't change for an individual. Your pelvic incidence is your pelvic incidence. The things that can change is pelvic tilt, which is essentially measured or an angle subtended by the femoral head to the midpoint of the sacrum and then measured against the vertical. And then what I would probably say about this one, if you think pelvic tilt, it's often a little bit misunderstood. A high pelvic tilt is actually where the pelvis starts to retrovert and the sacrum becomes more vertical in orientation. That represents a higher pelvic tilt. The sacral slope is measured as a tangent off the superior end plate and compared to a horizontal line. The pelvic tilt and the sacral slope taken together equal the pelvic incidence, and you can do the geometric proof if you'd like, but that's essentially what it is. So remember, pelvic incidence doesn't change. I'm going to go back. Pelvic incidence doesn't change, and it's the sum of pelvic tilt and sacral slope. So as the sacral slope decreases, the pelvic tilt must increase, and that's generally a compensatory mechanism. All right, so a variety of looking at what pelvic tilt really means, but remember that pelvic incidence in the normal person determines a lumbar lordosis, and it also determines the surgical target or number that we try to achieve. Lumbar lordosis should typically be the pelvic incidence plus about 10 degrees. And so a higher pelvic incidence is depicted here, and that means that essentially that you have a higher sacral slope and a lower pelvic tilt, relatively speaking, as opposed to a low incidence. And we know that people that have a high pelvic incidence tend to have a higher lumbar lordosis, and vice versa. So the surgical goal, as I said, is to be pelvic incidence. It's actually plus or minus 10 degrees is the ideal target. And the reason that you shoot more for the positive side is that in order to clear your leg when walking, you need that extra amount of a pelvic incidence. So the spine and the pelvis work together, and that certain things are correlated with others. For instance, higher pelvic incidence tends to lead to higher lumbar lordosis and higher thoracic kyphosis. Other numbers that we look at and pay attention to is this sagittal vertical axis. Okay, and we'd like that to be. It's actually measured from the posterior superior corner of the sacrum and taken from a plumb line to the midpoint of C7. That should ideally be less than about 5 centimeters or 50 millimeters. The pelvic tilt should be less than 20, and ideally the sacral slope should be the greater contributor to pelvic incidence. All right, so and in fact the normal numbers for that is that pelvic incidence tends to be 50 degrees plus 10 degrees or minus 10 degrees, and that sacral slope should be about 40 degrees, and pelvic tilt should be about 10 degrees. Those are rough numbers to keep in mind. But also remember that as we age, we become more kyphotic, and the sagittal vertical axis goal may be different as we get older. And so we can see that as we age, at the average age of 50, the SVA is about 5 centimeters. And then you can look as we age, that the SVA, so the sagittal vertical axis measured from the posterior superior aspect of the sacrum, tends to increase. All right, so the goal may be that as we get older, that we shoot for less correction, and we know that the more correction we do, the higher the likelihood we are to have a complication with correction. In other words, proximal junctional kyphosis. All right. So this study, and you can see the reference up there, basically demonstrated that sagittal spinal pelvic alignment varies with age, and therefore the conclusion is that younger patients require more rigorous alignment objectives as opposed to the older patient. And as we look at outcomes from deformity corrections, we see that somewhere over 20 to 25% of people still have SVA less than the ideal goal, and also pelvic tilt ending up being less than the ideal goal. So just a summary, and I'll repeat important points as I go through this. That's from a spinal pelvic alignment standpoint. Sacral slope, this line measured against the horizontal. Pelvic tilt, midpoint of the sacrum to the femoral head, measured against the vertical. And then pelvic incidence is essentially the midpoint of the sacrum to the femoral head, with the angle subtended by a perpendicular to the superior end plate of the sacrum. And that pelvic incidence is equal to sacral slope plus pelvic tilt. And remember that pelvic incidence relates to lumbar lordosis and our lumbar lordosis goals. All right. Just looking at a whole variety of spinal pelvic alignments. I'm not going to say much about this other than, these normal numbers that we talk about. So pelvic incidence average about 52 degrees, pelvic tilt about 12 degrees, and lumbar lordosis 60. So that gets us to that about plus 10 that we'd like to see, and that's normal spinal pelvic alignment. And this is done in asymptomatic individuals. Remember, as we start to compensate, the lumbar lordosis may change, pelvic tilt may change, sacral slope may change. All right. Remember that also that I said that from a pelvic tilt standpoint, it should be the lower contributor to the pelvic incidence, so less than half. Sacral slope, and ideally only about 20% of it. And that sacral slope should be more than half. All right, pelvic incidence doesn't change. I said that. So as you know, spinal alignment and anatomy is variable. So if you look at an asymptomatic population, Rasooli and his colleagues categorized spinal alignment, or it's alignment, in an asymptomatic population, and came up with essentially 4 different curve types that people have. And if you look, this is a highly tilted pelvis, so the pelvic tilt is high here, and as you move through these, you see that the pelvic tilt becomes lower, sacral slope increases, but also that in each of these different curve types, that as the pelvic tilt decreases and the pelvic incidence increases, that the lumbar lordosis is higher and the thoracic kyphosis is higher. And we know that these things are very well maintained as we seek to keep our head over our feet, which is the goal of all spinal alignment. You'll see that almost half the population has this type 2 Rasooli curve type, all right? And that a small percentage have this type 1, where there's really very low pelvic incidence and high pelvic tilt, with less lumbar lordosis and more thoracic kyphosis. So these are the basic curve types that are described, and it forces us to realize that in the asymptomatic population, that there's quite variable anatomy of the spine. And I'm not going to talk anymore about sort of normal parameters. We've talked about them. But remember that the goal of all spinal alignment and balance is to keep the head over the feet. Patients become symptomatic when we're not able to do that, and so we have compensatory mechanisms that we utilize by increasing lumbar lordosis or thoracic kyphosis or cervical kyphosis in order to keep our head over our feet. So I'm going to spend some time now talking about cervical parameters, which had really, I think, been ignored for the most part over the years, or not felt to be as much of a component of spinal alignment. And now we're beginning to realize that cervical parameters also enter into our consideration. And that brings us to this concept that balance is a global spine phenomena. It's not just isolated to the thoracolumbar spine and not just isolated to the cervical spine. So it's certainly not as well characterized as standardized as the thoracolumbar spine. And in fact, there are a variety of new measurements that are coming in, and that'll be the last couple slides in the whole talk about how we have developed some new things that we're looking at, but once again, not well characterized. So there's a wide variety of causes to cervical deformity, whether it's spondylosis, inflammatory, traumatic, congenital, neuromuscular, or iatrogenic, which means that we've created the problem, not putting enough lordosis into our constructs, or not paying attention to the fact that the spine is out of alignment, fusing people in a not ideal position. Remember that the most common deformity that we have is kyphosis, and that can be fixed or non-fixed. Certainly when it's fixed, it takes away the ability to compensate for malalignment in the thoracolumbar spine. Really, there's no standards at this point to indicate how much correction is needed. I think it's probably safe to say that older people tolerate malalignment and poor balance as opposed to younger people. People have spent their entire lives getting used to the alignment that they're in. There's a classification system that I'll talk about that was that was put together. It's not well validated yet, but at least it serves as a platform to discuss cervical deformity. And then there's a relation of kyphosis and myelopathy that's becoming more important to pay attention to. We know that patients that have higher degrees of kyphosis will develop myelopathy. This is primarily related to greater cord tension or spinal cord tension, which the spinal cord tolerates less well than any other stress. It's been demonstrated also that there's increased intramedullary pressure with kyphosis, and this leads to decreased vascular supply, which leads to cord injury. Perhaps one of the most important things that patients present with cervical deformity is pain, and we'll talk about some of the physical findings that people have. Now, these are all patients, and I just took this from Ed Benzel, that have poor cervical alignment. And what you may notice, and the most common theme here, is that most of these patients are kyphotic, and you'll notice a couple things. Because of this cervical kyphosis, the compensatory mechanism goes through the mobile parts of the spine, which is primarily lumbar spine, and patients develop more lordosis. They develop perhaps a little more thoracic kyphosis, but remember that the thoracic spine is relatively more fixed. So the major compensatory mechanism would be to have more lumbar lordosis. All right, and you can see, and I'm going to show you that this is fairly common. So the bellies protrude in each of these patients. It looks like their shoulders are held fairly far back. And then the other thing you'll notice is right here along the trapezius that the trapezius is always tense. Ed Benzel has called that the kyphosis trapezius sign. And it's simply a clinical observation that he's made over the years, and that occurs in patients that have thoracic kyphosis. The mechanism is that patients are trying to hold their heads back to compensate for their kyphotic deformity and develop this constant firing of the trapezius muscle. This leads to neck pain as the muscle fatigues. Some patients, as I said, are able to compensate for it. Others are not. The other interesting thing that's been noted is that sometimes patients that, in this case, that was basically fused in too flexed a position that ended up with a compensatory mechanism of basically leaning back, and you can see her thoracal and lumbar alignment. She's in fairly negative thoracal lumbar alignment and balance. And in fact, this patient presented with back pain because of her poor cervical alignment. So head flexed as she's trying to look up and maintain a horizontal gaze. She develops this hyperkyphosis of the thoracic spine as more of a long-term compensatory mechanism, and then is basically unable to really compensate adequately through through her lumbar spine to keep her horizontal gaze, and develops back pain related to that. And this patient actually underwent correction of her cervical problem to achieve resolution of her low back pain. And once again, just another patient that you can see with this firing trapezius who has neck pain, kyphotic deformity, firing of the trapezius muscle, resulting in neck pain. Alrighty, so we also talked about this concept of cervical spondylotic myelopathy being related to tethering and traction on the spinal cord. This is a patient that basically wasn't fused but had a laminectomy, developed post-laminectomy kyphosis, and even though and I'll show you the images, had a relatively good-looking post-op MRI, developed signs and symptoms of progressive myelopathy, and you can see on a flexion film that the patient does develop some kyphosis. With that, this patient underwent. I'm going to go to the next picture first. Underwent flexion MRI, and as you can see here, this is the standard MRI that we would get. We would see that the spinal cord looks relatively well decompressed. However, in flexion, the patient drapes the spinal cord over the kyphotic deformity, and also because of the scar tissue that basically is running from the over the exposed area, develops further posterior compression on the spinal cord. So the correction of this is simply to fuse the patient in a more relatively well-aligned position. There are normal numbers that we talk about for cervical alignment, particularly in adult patients, and this is taken from the literature. But the important point of this whole slide is that the majority of lordosis in the cervical spine falls in the upper segments, essentially from the occiput down through C2, or even if you want to include C3. All the other levels have relatively lower levels of lordosis. In fact, you can see that the cervical lordosis tends to only be about 9.6 degrees from C2 to C7, whereas the total cervical lordosis from C1 to C7 tends to be 42 degrees. So we know that the only additional segment in here is C12, and you can see from these numbers that there's about 32 degrees of lordosis at C12. Something for us to pay attention to. That's the compensatory mechanism, and probably thoughts and considerations for us to think about as we do operations on the cervical spine. We also know that cervical lordosis peaks, at least in males, at about 40 to 45, and then diminishes over time as we become more kyphotic. And remember that aging is a kyphotic process. So as we talked about thoracolumbar parameters, let's talk about some important cervical parameters. And the ones that have gotten sort of the most discussion are: one, cervical lordosis measured from C2 to C7, so inferior end plate of C2, superior end plate of C7. Drop a perpendicular off of each of those, and then measure this angle. This is the cervical lordosis from C2 to C7. Remember, that's only going to be somewhere about 10 degrees. The other thing that we started to pay more attention to is this T1 slope, which is essentially an angle subtended by a tangent off the superior end plate of T1, and compare that to a horizontal. And some of this comes into the consideration of what's going to fail as we approach the cervical thoracic junction. So patients with a higher T1 slope may have a higher likelihood of further problems at C7 T1 if you're only fused to C7. The other angle that we've talked about some is this chin-brow vertical axis. So across the brow and across the chin, measured against a vertical. And we know that the ideal sort of angle for this is about 10 degrees. The reason is that we like to maintain horizontal gaze, but we'd also like to be able to see the floor, which is essentially relatively important in how we do things. And keeps us from falling. So there have been a bunch of ways that people have talked about measuring cervical lordosis and what's the most accurate way to do it. And we know that one method, such as this, sort of underestimates lordosis. This method, which is just a tangent off of C7 and a tangent off of C2, tends to overestimate the cervical lordosis. Other people have said that you measure the angle at each off a tangent in the posterior body of from C2 to C7, and measure that against the vertical line, and then decide if that is and then have the total summation being the cervical lordosis. Additionally, there's this Ishihara index that's been talked about, and that's basically measured off a tangent from, and the index is derived from a tangent, a line from C2 to the inferior part of C7, and then at each disc space, measuring the distance between that line and the disc space, and then summing all these and dividing it by this length. And there are numbers, and I don't know what the numbers are, but it's at least a method of saying adequate cervical lordosis or not. The other thing that's become important is this C2, C7 vertical axis, so what's commonly called the CSVA, and this is measured from the centroid of C2, all right, off a line drawn from the posterior superior aspect of C7, and that line is basically measured, all right. This distance, this is what we've talked about before. That number we'd like to see less than 4 centimeters, and that the normals for these are derived from patients that have become symptomatic, knowing that higher than 4 centimeters off tends to indicate that patients may not do as well. And people have looked at a variety of other things. People have measured from the anterior tubercle of C1 and measured that distance, or the sort of center of gravity line, which is measured from the anterior portion of the external auditory meatus, and then has a vertical or a plumb line dropped and measured off that posterior superior aspect of C7. All of these things are essentially very well correlated to one another. And the one that seems to be gaining the most attention is this C2 to C7 SVA. Remember, chin-brow vertical axis, just as a reminder, there's 2 ways that you can get this measurement. One is off of clinical appearance of the patient, which they've done here, versus radiographs. And remember that as we get radiographs, that you'd like to obtain them with the knees and the hips extended. It's very important for all the thoracolumbar and the cervical films that you get quality films, and that the films are obtained with proper technique. It's often hard to gauge this, since we don't generally see the leg position on most radiographs. So we have to assume that the radiology techs have obtained them adequately. Once again, just a reminder that that this is not just a cervical spine phenomena, not just a thoracolumbar phenomena, and that it's a global consideration. So remember, once again, I said there's a bunch of ways that people have done this. This is the center of gravity SVA. There's the C7 SVA that we talked about earlier, and then there's this measure also off of a C2 SVA. So a bunch of things that people are measuring. I think we're still in the process of figuring out what's relevant and developing standardization for this. So one of the other things that's been talked about, and this will be similar to pelvic incidence, pelvic tilt, and sacral slope, is looking at the thoracic inlet angle. And this is being correlated with clinical findings, etc. This is a very busy slide that talks about a variety of things, but the one thing I want to concentrate on is this one. This one probably shows it better. All right, and this so neck tilt is similar to pelvic tilt. All right, and that's measured basically from the superior end plate of T1 down to the midpoint of the manubrium, measured off a vertical, which is exactly what we do with a pelvic tilt. And then the other one is the T1 slope that we've already talked about, which is tangent off of T1 measured against a horizontal, similar to sacral slope. So there's a slope and there's a tilt, and then this T1 pelvic, or this inlet angle is essentially measured as a perpendicular off the superior plate of T1 versus the manubrium. And we know that when we look at x-rays that this is a very hard area to see on film. So this may be more difficult to obtain. And there's not well thought out numbers yet as to what's normal for this and what we target. Just knowing that patients that have a large slope may have a higher tendency to fail. High slope also correlates with higher thoracic inlet angle, as we would imagine. And this number of thoracic inlet angle may vary some, because this is not quite as rigid as a pelvis, right? There's 2 articular processes between the manubrium and T1, but it's relatively not changeable. So what are the things that are associated with lower health-related quality of life indices? And once again, this is just derived from evaluating patients that have had issues and seeing what the cutoffs are. So the things that we've already talked about is this SVA being so the C2 to C7 sagittal vertical axis being more than 4 centimeters. So we've talked about that. We've also talked about the chin brow vertical axis being more than 10. So meaning that we're starting to stare at the floor, and I'll show you some other numbers for that later. The other thing is that if you're hyperlordotic, more than 10 degrees, this also starts to fall off as far as quality of life goes. And then this T1 slope minus the C2 to C7 cervical lordosis being more than 15. And this is simply an indicator that we're using a lot of cervical lordosis to compensate for that higher thoracic inlet angle, and that we eventually reach a point where we can't compensate anymore for it by increasing our lordosis. So you like to keep that T1 slope and the C2 to C7 cervical lordosis within about 15 degrees of one another. Remember that this gets down to the global balance or global or alignment being sort of a global problem and not just isolated to a thoracic spine or a lumbar spine. That the cervical, thoracic, lumbar, and sacrum, i.e. and pelvis, really don't function independently. In asymptomatic patients, we know that, and this is asymptomatic patients, not patients compensating, that pelvic incidence correlates with lumbar lordosis. So higher PI leads to higher lumbar lordosis. Lumbar lordosis also correlates with thoracic kyphosis. All right, more lumbar lordosis generally has patients generally have higher thoracic kyphosis, and that thoracic kyphosis correlates with cervical lordosis. So more thoracic kyphosis, more cervical lordosis. That's because the cervical segment tends to be a compensatory segment. But we also know from looking at the literature that there's a lack of correlation between pelvic incidence and thoracic kyphosis. And this is because the pelvic incidence is fixed and there's relatively less flexibility in the thoracolumbar spine, even though lumbar lordosis itself is related to pelvic incidence and thoracic kyphosis. And once again, this is in patients that are not compensating for abnormal alignments. So as more consideration as thoracic kyphosis increases, cervical lordosis tends to increase, but you eventually get to the point where you're not able to keep your head over your feet, but at least to some degree, the goal is to have more horizontal gaze. And remember that cervical lordosis typically doesn't include the occiput and C1 articulation. So even though you can't compensate with cervical lordosis, you tend to do more so with more head tilt. All right, just an example of how people, what happens to their alignment in order to keep their head over their feet. Not much really to say. Looking at hyperkyphotic C-spine, and this is a relatively, it tends to indicate a patient that's fixed, and this is the example of the patient that I showed before, in that they tend to be a negative, they have a negative sagittal vertical axis, tend to be hyperkyphotic, and compensate as much as they can through the lumbar spine, and then also compensate by having increased head tilt, as opposed to the hyperlordotic cervical spine. In these patients, the C-spine still tends to be mobile, but you end up with relatively flat back, higher pelvic tilt, less thoracic kyphosis, and once again, trying to maintain an upright gaze and keeping your head over your feet. So let's talk a little bit about a classification system that's been developed. And if you look at all the authors here, these are thought to be people that spend a lot of time talking about thoracic spine and doing deformity operations. And why have a classification system? Well, I think it's the obvious reasons are, one, it facilitates research and it facilitates communication. At some point, the goal is that this should guide patient management. Now, it's an iterative process in that what is developed now may change down the road as we start to do more research and have further discussions about what's important as far as balance and alignment go. So it may change. And we have already said that the most important parameters are not well defined in cervical deformity yet. And I'm not taking credit for developing this system. I think it's a great start. And so here are the parts, and we'll talk about each part individually. One is, let's talk about this, what the cervical deformity classification is. And it basically has the deformity descriptor and it has modifiers. All right. So the descriptors are essentially where is the apex of the deformity? Is it in the cervical spine? Is it at the cervical thoracic junction? Does it sit in the thoracic spine? So more kyphosis, and that the cervical deformity is a result of thoracic deformity, which is actually very common, or is it primarily a coronal deformity? And we haven't spent much time talking about coronal alignment, but it is also a very important consideration. And then CVJ is simply the descriptor that talks about the craniovertebral junction. So the modifiers are the C2 to C7 vertical axis, horizontal gaze, cervical lordosis minus the T1 slope that we said we'd like to be less than 15, myelopathy using the modified JOA, and then the Schwab classification, which and the SRS Schwab classification, which is essentially the descriptor used for global spine assessment and thoracolumbar deformity. That's very well validated at this point. All right, so we know, as I said earlier, that the C2 to C7 SVA is correlated in studies looking at health-related qualities of outcome, and we already talked about how it's measured, and the modifiers are described as 0, 1, and 2, and it's basically less than 4 centimeters is a 0, and you can read this. 4 to 8 is a 1, and greater than 8, so a significant malalignment with the head way out over the cervical spine, being an 8. So this simply just represents, at least at this point, what are viewed as increasing severity of malalignment. We've already talked about this horizontal gaze modifier, this chin-brow vertical axis. We've talked about how it's measured either on clinical appearance in pictures versus radiographs. We've already told you that the optimal target is about 10 degrees. That allows us to see the floor and maintain vertical gaze. So if you get between 10 and 25, that's still okay. But when you get to greater than 25 degrees, and actually, I'm surprised it's not in here, but less than -10, because I think that's one of the, at least that may be the newer thing. If you get to more than 10 degrees negative, so looking up more than that, that also tends to be problematic. So the greater than 25 degrees, you tend to be really staring at the floor, and the greater than a -10 means that you're looking way up and may not be able to see the floor, which is bad for survival. And we've talked some already about this T1 slope minus C2 to C7 lordosis, and we know ideally that we'd like it to be less than 15 degrees. And they've got this backwards, but in any event, I said lordosis minus T1, but you'd ideally, it gets to be somewhat problematic when you're between 15 and 20 degrees, and really much more problematic when you're greater than 20. The myelopathy modifier is essentially the modified JOA. I'm not going to spend much time talking about it, but essentially numbers are derived by looking at mild, moderate, or severe. And then the Schwab classification is the SRS Schwab classification is a well worked out, well validated scoliosis classification system that primarily looks at coronal curve types. All right, so this is the descriptor. These are the modifiers, and you can look at all these things. But these concentrate more on thoracolumbar spine, which brings the global perspective into all of this. So I already talked about films and what good quality films are, including lateral C-spine to include the skull, AP and lateral scoliosis films, and the hips and knees need to be extended. This allows you to make all of these measurements that we've talked about and developed these descriptors. Once again, the classification system is relatively new and still being worked out. Additionally, people are starting to measure all sorts of stuff to bring global alignment into this, including this C2 measure. So it's a tangent off of the back of C2. This is measured against the vertical, but then you draw a line all the way down, and that line essentially intersects the line drawn from the femoral head to the midpoint of the sacrum. This angle is measured. It's known as the C2 pelvic tilt. I'm not sure where that's going to go. The radiograph next to it simply is a representation of how to look at these things together. Once again, a measure of global alignment more than anything else. The other number that's beginning to be looked at as looking at global alignment is this T1 pelvic angle. And this is measured essentially like pelvic tilt, so same pelvic tilt measurement here, looking from the femoral head to the midpoint of the sacrum, and then measuring that as a plumb line from the centroid of T1, and this is known as the T1 pelvic angle. There are numbers being developed for this as far as what's normal and what's abnormal. This is my reminder to once again say this is a global process. The cervical spine and thoracolumbar spine do not operate independently. Another measurement that we're not going to talk about. And then looking at these measurements once again and comparing angles and using them as descriptors. I think everybody and their brother is now developing something to measure and trying to correlate. It's important. I think we still have to work that out. So just a brief discussion of things that we can use to correct things. And this is primarily going to be focused on cervical spine, and this will be very brief. The first is gravity, right? What we want to do is put our patients on the table and see if we can correct their cervical malalignment with just gravity. And I think we need to pay attention to this as we do things. Gravity also affects thoracolumbar deformities as well as flexibility of curves. So you can get a lot by just utilizing gravity. All right. Another mechanism to obtain correction is basically segmental correction. So you're doing individual discectomies, as in this patient. So this patient actually had posterior releases. All right. As you can see, so facetectomies, following the nerve root all the way out, leaving enough lateral mass to obtain fixation if you need to. But in this case, it was basically just used as a release. And I will tell you that in my cervical deformity cases, I always tend to do the posterior part first and do the facetectomies first, because you know that once you are released in the back, that you are released, and that if you're going to get correction, you're going to have to do it through anterior releases. And so this patient went on to have multi-level discectomies, and you can use wedge-shaped grafts to get you even more, and then utilize the plate by fixing it at either end first, and then using the screws in these intervening bodies to pull the spine to the plate. But I would tell you that once you've done the posterior release and you get an anterior release done, that you're likely going to be able to get fairly good reduction with the assistance of gravity. We've already talked about this case. This patient underwent posterior releases and then correction through a posterior primary approach. And then just remember this concept of sometimes leaving an intervening body if you do a corpectomy at, for instance, C4 and C6, and then using this intervening body as a mechanism to achieve lordosis by pulling the vertebral body to the plate to achieve your lordosis. So a variety of mechanisms that we can use, and these are these recently described 7 grades of basically resection or releases that patients can undergo to achieve correction. So just the discectomy without through basically mobile disc spaces, or once again these facet resection osteotomies. I'm not going to give them a name. With releases posteriorly. So once again, you need a mobile disc space for this. Grade 2 is a wider resection with exposure out over the nerve roots. Grade 3 is a vertebral body resection. Grade 4 takes you all the way out through the uncinate processes. Grade 5 is an osteoclasis, essentially fracturing someone through an ankylosing segment. And then this is a pedicle subtraction osteotomy that can be done, or this is a complete vertebral section with both anterior and posterior. So each representing higher degrees of instability. We also know that in the thoracolumbar spine that we have a variety of osteotomies that we can do, and they have 6 grades of destabilization, from partial facet resections to complete facet resections, partial body and disc, complete body and disc. And that's just depicted here. as ways to, and the six grades of destabilization. All right. So in closing, I just want to clue you into this article that was published in Neurosurgery just recently. So it's a 2017 article that talks about recent and emerging advances in spinal deformity. And in this article also, and once again, by sort of the thought leaders in this area, and it allows us to have this consideration of global issues rather than just isolated to one area of the spine. So new measurements being brought in this article to talk about. And I'm not going to spend much time talking about it. You can see it, all the description is down here, looking at these angles. In this one, actually, at least the thought on this is now we take into account these sort of compensatory mechanisms where patients may not have films with their hips and knees completely extended, because if you're not completely extended, you can see that you're going to change these measurements are not going to be exactly the same. The SVA will be different. So it actually takes into account this from the sacrum, and they call this the piscia, from the sacrum to the anterior portion of the tibia. So that's a lot of information to share with you. I'm happy to answer any questions you have, but once again, thanks for inviting me to do this.
Very great, very good, Greg. Thank you very much for a complete, exhaustive, comprehensive look with great illustrations. Just click on the arrow, Greg, to get off the screen share so we can see you.
Yeah, I don't want you to see me.
Oh, okay. Just click on the far left, the screen share button.
Yeah,
there you go. There you go.
Good.
There you go. Okay, Victor, do you have any questions or comments for Greg?
No, I am very impressed about the conference. Really, really good. I think most of the neurosurgical and orthopedic community should see this conference. It was really, really, really good. And congratulations, Gregory Rast. Very nice conference.
Thank you.
Yeah, okay, Greg, just a question from a non-neurosurgeon. Do you make basic measurements for all your spine patients?
So what I probably will say, the reasonable thing that we're starting to do now is that on all of our lumbar fusion patients, we are getting scoliosis films on everybody. I'm not doing quite as comprehensive of a measurement as we are in that I presented, but certainly over the years we're developing the need to do scoliosis films, because I think we've become aware of the fact that almost every operation we do is a deformity operation, and that even the single level or two level lumbar fusions can result in significant malalignment issues that may require intervention down the road. But certainly all of our cervical patients get cervical films, all of our lumbar fusions get scoliosis films. And I think it's becoming relatively more common, but not universal.
And are there situations where if you have a patient with a deformity or measurements are way out of whack, mm-hmm. do you suggest surgery before they begin to have a problem, or you kind of wait till they get symptomatic?
Nah, you can't make a well patient better. So
yeah.
If someone's asymptomatic, you don't do it. These operations, even in the best of hands, still have about a quarter of them still have a malalignment issue. They tend to be older patients, and so really we try to get people to exhaust all non-surgical things before you undertake this. And the outcomes may not be as good as you'd like. I think people that do these surgeries should do it a lot and have a lot of experience. It just shouldn't be someone casually doing it.
When you say non-surgical measures, you mean wearing braces and belts and?
We tend not to do braces and belts. We tend to have people go to physical therapy. And I think sometimes the real question in all these is whether to try to do something small versus something big, whether it's a radiculopathy issue versus a axial pain issue. I think trying something small may be better. There's a lot of people that have degenerative scoliosis that have an L5 radiculopathy. In fact, those patients may respond very well to just a single level foraminotomy as opposed to a big deformity correction.
Is a large part of your practice scoliosis?
No, almost none of it. I do a lot of degenerative surgery. Like I said, every operation I do is a deformity operation. I tend to do more cervical deformity than I do thoracolumbar deformity. I have a partner that specializes in thoracolumbar deformity. So
and there's plenty of patients with those deformities, huh?
Yeah, there's very few that are probably really good surgical candidates.
Yeah. Okay.
Although there are people out there that make their whole living doing thoracolumbar deformity.
Really? Okay. Very good. Okay. Okay, Greg. Thanks a lot for taking your time on a Sunday.
It's early Sunday morning here.
Sure. Yeah, it's Sunday night here in Nepal.
Yeah.
And how are the Badgers doing?
Badgers won 45-14 yesterday. They're 9-0.
Oh my God!
They're getting no respect from the college football playoff people, though. They're ranked 4th in the country in most polls, but they're 9th place as far as the college football playoffs go.
Well, the big rival, not Ohio State, is the rival, right?
Yeah. Well, Ohio State got killed yesterday.
Really?
They lost to Iowa 45 to like the Badgers 45-14. Badgers play Iowa next weekend.
So Wisconsin's near the top of the heap.
Yep. Yeah, have been for a while, but they're not the 4th best team in the country. They're probably the 9th best team.
Oh, okay. Well, we'll see. Okay, Greg. Well, thank you very much. We'll edit it and we'll send you a copy. Thank you.
All right. Thanks for having me.
Thank you.
All righty. Thanks.
Okay.
Bye-bye.
Bye-bye.
See you, Victor.
Bye-bye. Congrats.
Okay, Victor, you guys, we have one more talk, Victor. I don't know if you want to, I hope you hang around, but whatever.
Now I like to go to make some exercise, but I want to tell you something. You are doing a very great job because these conferences are really good. So most of the neurosurgical community should see these conferences, and you are doing very exhaustive job about this because you are working very hard. So congratulations, dear friend John Bennett.
Well, Victor, I look forward to coming home to Miami. I'm coming down to Mexico City for sure in March.
Yes, we are going to visit some places here in Mexico.
Oh,
I am really happy to have your amistad.
Oh, yeah, well, Victor, I miss Mexico because, as you know, I went to school there a couple of years, and I haven't been back there since. To Guadalajara, Universidad Autónoma de Guadalajara, and I always liked Mexico, and I'm looking forward. I might come there earlier than March. We'll see how it goes because I'm getting such a positive feedback from the Spanish neurosurgeons. I'm really getting very positive feedback, and now I have some people to help me. Luis Moscote, he's a neurosurgeon. He's helping me a lot. The Nicaraguan medical student is helping me, so we're really doing well. I'm looking forward. Okay, Victor, have good exercise.
Yes, thank you so much. So later I like to have me gustaría tener la clave, John Bennett, para revisar estas pláticas, las de TV Neurosurgical.
Sí, yo voy a mandar links sin editar y después de editar yo voy a mandar. Todo va a estar separado. Tú vas a tener tu charla y Greg va a tener tu charla separado. Nosotros vamos a hacerlo. para
Sí.
todo.
Y para revisar otras pláticas que se han dado.
Sí, sí, sí. Ok, Víctor, gracias para su asociamiento.
Sí, gracias, gracias, que estés bien. Saludos, Marco Antonio, un abrazo
Hasta luego.
desde México.
Muchas gracias, profesor. Saludos.
Bye.
Okay, bye-bye. Okay, Marco, you got perfect attendance. You're gonna make the last one, right? The last one is Jay. He's gonna talk about. Let's see here. I think
I'm not sure. I have to go.
significance of VA for cervical spine injury. I don't even know what VA is. VA, vertebral artery, maybe vertebral artery. I don't know what
Oh.
VA is.
I'm
But,
really sorry, but I have to.
Well, yeah. Well, I'm just gonna keep rolling because rather than start another another link. Well, maybe I could start another one to make it easier for Simon to. No, we'll wait because I think Jay's going to come any second now. Boy, it started off really rough because we had some technical issues. I don't think you were around yet, but the in the office here, when the computer went down twice, totally. I was in the middle and with Salman, and it went off. And because they moved some equipment here twice. Man, I said, don't touch it, man. We're televising. And then we got booted back on. But thank goodness Salman has experience, and he kind of took over when I was gone for like 5 or 10 minutes, and he kept it rolling, kept the conversation going. That kind of saved it. Otherwise, it would have been a disaster. And then we had some issues with sound with one presenter, but then it kind of got going, and Greg was really good. That last talk, it got smooth, and the presentations went okay. So let me check here with Jay. Hold on.
It's Professor John. I have to go now.
Okay. Well, okay. Okay, well, thanks for your support. I understand. You put a lot of time in. No problem. Okay, then we'll do this last one, and we'll see you soon.
Yes. Dr. Griselda is going to have the conference.
Oh, she wants to have. When does she want to have it?
Yeah. Do you know when it's going to be?
No, when does she want to have it, Griselda?
Wednesday? No, Wednesday is.
No, she usually Thursday. Thursday, she usually has it Thursday. Yeah. No. Yeah. I love to have it. I didn't know if she was back from Canada because you know how she went to Canada.
Okay.
And well, hey Marco, I'm coming down to Mexico for sure in March.
March. How long?
Well, because Erica and Fernando invited me to that conference to receive the award.
Perfect.
Yeah, that was very nice. That was very nice, and they said they'd pay for the flight and the hotel, so I'm gonna go. And I'll get to meet Victor and Fernando and
just
Erica.
For that, Congress or how long?
Yeah, it's for a convention. Yeah, I'll be there probably for the week. Yeah, I'll be there for the week.
Okay.
So things are going really good in Latin America because I've got Alexis helping, and now Lewis is helping. So I'm really getting good feedback from those Latin community, and we have a couple of conferences come. We have one on the 15th from Bolivia. Do you know those guys?
They're from Oruro. It's going to be in Oruro.
Yeah. Well, Jornada. You saw? Did I send you the description of it?
Yeah.
Yeah.
Yes.
Yeah,
Yes. Got it.
Jornada with Albert Campero. He's a big neurosurgeon from Argentina.
Yes, I saw it. I saw it. And next Sunday, do
Uh,
we have anything? Next Sunday.
hold on. I got Phil. Yes. Hold on. Okay. Time to go home. Right? No? Okay. You see, I'm on TV. Look, I'm on TV. Look, I'm on TV. Look. I'm on TV. Look at it. Come here. I'm going to show you. Let me show you. I'm on TV. How you doing? Yeah, it went well. Victor gave a present. Greg Trost. Do you know Greg Trost? How you doing today? Tired? Yeah. You look good. Right. Yeah. Yeah, it went okay. Yep. Okay, good night. Okay, yeah,
Okay, Dr. John.
there's one more. Yeah, okay, Marco. Yeah, thank you for support.
Okay.
Okay, see you
soon.
later. Bye-bye.
Bye. Bye. Thank you.
Okay.
Hey, can you hear me?
Hello, Jay.
Oh, I'm Jay.
Oh, okay, good. I wasn't sure whether you got my message.
So how can I show my presentation?
How you doing? Do you want to review how to screen share before we start? Yeah, why don't we just review it to make sure you you understand it, and then before we start.
Okay.
Okay, not yet. Okay, yeah, there we go. Yep, there we go. Okay, it's a little small, the screen. If you could make it bigger, the present there, that's beautiful. Can you change slides, please?
Okay.
Change slides.
Yep.
Yeah, okay,
I
it's
change it.
working. It's working fine.
So
Yeah, it's
are you ready?
yeah, it's working fine. Okay, let me introduce you and then we'll start, okay? Okay, why don't you get off the screen share for a second while I introduce you? JTech. Just click on the green arrow to get off it. The far left on the screen share arrow. Click on it again to get off. It's in on the left column of the present screen share on the left, the green arrow. Click on that to get off the screen share. No, on the left column, the left side. No, the left column on the screen share on the left, the far left of the screen. Yeah, that's it. There you go, up there. Yeah, on the left, the screen share button. On the left, on the far left, far left. Okay. Okay, there you go. You're off. You're off. Okay, very good. Let's start. Let me just introduce you first. 10, 9, 8, 7, because we edit all this. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good evening. This is Dr. John Bennett broadcasting for Neurosurgical TV for the conference of All About Spine. We're collaborating, Neurosurgical TV is collaborating with the ACNS. And tonight we have the pleasure of having Dr. Jay from Korea. He's going to give a presentation, and I'll let him introduce himself and tell him the title of his talk. Good evening, Jay.
Hi, good evening.
Could you please tell us a little bit about yourself and what you do, and where you trained, and where you're practicing now, please?
Okay, nice to meet you, everybody. I'm Jae Kong from Catholic University of Korea. I'm a neurosurgeon, and I graduated at Catholic University, and my specialty is spine surgery, especially for the cervical spine.
Very good, very good. Okay, and what is your presentation tonight?
So today, I'd like to talk about significance of vertebral artery injury in the cervical spine, especially for upper cervical spine.
Okay, very good. Okay, let's see if you can do it.
So first I have to click green button.
Right. Just like you did before. Very good. That's excellent. Excellent.
So my topic is about significance of vertebral artery for cervical spine surgery. So I'd like to talk about the vertebral artery injury around upper cervical spine. I'd like to review anatomy of the vertebral artery for the surgery. And so important thing is vertebral artery variation and different surgical strategies. For example, various entry point for C&R screw and a different type of screw for C2 screws. And I'd like to review some my cases and summarize this. As you all know, cranial junction is a very difficult area to do surgery because there could be lots of critical neurovascular structures around there, such as the vertebral artery, spinal cord, nerve root, and pes plexuses, and intercapsular artery in front of the upper cervical spine. I'd like to show vertebral artery injury during the surgery. Here's a video clip for upper cervical spine fixations. I first place the C1 screw like this, and then I try to place C2 pedicle screw even though patient has a high riding vertebral artery, but I make entry point in the superior medial part of the C2 part. So I made an entry hole, but there's a huge blood bleeding during the surgery. It is a vertebrae injury. When it occurs, you can find out that it could be very dangerous for not only for the patient but also for the surgeon. So you can try everything to stop bleeding. Most important thing is using your fingers first and to occlude it. Another important thing is you have to place the screw to occlude the vertebrae. Unfortunately, patient does not have any sequel about after the vertebrae occlusion, but because it's not a dominant vertebrae, but you have to avoid this type of complication as much as possible. After the surgery, you can see the trajectory of the screw. See, the screw is lower than I expected, so that's the reason why we damaged the vertebrae in the surgery. Even though it's very rare, but it is possible. So vertebrae injury is possible complication during the surgery. There's a lot of literature about the vertebrae injury in the cervical spine surgery. Most of the surgeons experience those kind of complications in anterior spine surgery.
Excuse me, Jay.
Yeah.
Yeah, can we? Your sound is kind of garbled. Is there anything you can do to the sound? Either get closer to the microphone or adjust it, because your sound is not very clear. It's okay, but I think it could be clearer.
How about this time?
No, it's
is it
still
better than before?
It's still a little garbled. Maybe adjust. So I don't know what to do, but do you have a mouthpiece or something you could hold close to your mouth?
Okay.
To make
it better?
A little better. Try to something a little different.
Mm-hmm.
You're using Wi-Fi, correct?
Yeah, I'm using Wi-Fi.
Oh, that's probably why. Well, okay, I guess it's adequate, but I guess it's the best we can do. Okay, carry on. Carry on.
Okay, thank you. So,
yes.
Vertebrae injury is a possible complication during the surgery. I'd like to change my headset then.
Yeah, that's probably. Let's try it. Let's try it. It's worth it. Let's try it. Okay.
Is it better?
Yes, it is.
Oh, okay. So, in the literature, vertebrae injury is very rare, especially for anterior cervical spine surgery. But in the posterior cervical spine surgery, it's much more common than the anterior cervical spine surgery. For example, upper cervical spine fixation, there could be 8% incidence of the vertebrae injury. Also, pedicle screw fixation is a very risky procedure for vertebrae. And vertebrae injury usually causes severe bleeding or ischemia because of the brainstem infarct. If you occlude the vertebrae, you can cause severe degree of cerebral infarct or brainstem infarct. So it's a very devastating complications. There could be lots of risk factors about the vertebrae injury. For example, abnormal course of the vertebrae, and also inadequate instrumentation technique can cause vertebrae injury. And also, disorientation during the surgery, such because of the tumor or infection or surgeon's inexperiences, and distorted landmark can cause vertebrae injury. There's a full segment of vertebrae. For example, V1 is a prevertebral segment, and V2 is a vertebral intraforaminal from C2 to C6. And also, a V3 segment is extraspinal around the C1 arch. And V4 segment is intradural segment above the C1 arch. Usually, vertebrae injury occurs around the V2 segment and V3 segment because most of the common cervical spine procedure you use this surgery around this area. Surgeon works very close to the V2 or V3 segment in a number of commonly performed cervical spine procedures such as instrumentation, corpectomy, foraminotomy, and discectomy. Nowadays, we usually use a C1 to segment fixation because it has a lot of advantage over transarticular type of screw fixations, such as direct manipulation is possible, and you can use this type of instrumentation for obese patients and thoracic kyphosis patients, and also less risk of vertebral injury will be expected using this technique because the entry point is superior medial quadrant compared to the transarticular type of screw, and trajectory angle is less steep. But still, there's a lot of challenges doing upper cervical spine fixation techniques. It's because it's uncommon procedures, and craniovertebral junction is very unique biomechanics, and there's a critical surrounding neurological structures around here, such as spinal cord, vertebral artery, and venous plexuses. Vertebral artery injury usually caused by technical problems, and there's another risk factor such as anatomical variations, V3 segment anomaly, posterior ponticulus, and high riding vertebral artery for C1 to transarticular cycle screw fixation and to C2 pedicle screw fixations. You usually place the C1 screw at the center of the C1 lateral mass, and medial entry trajectory is very important to avoid the transverse foramen injury. But if you make a lateral trajectory, it can cause vertebral artery injury, and you can occlude the transverse foramen and occlude vertebral artery. And if you make an entry point in the lateral part of the C1 lateral mass, you can damage the vertebral artery also, like this. Here's a cases of the true lateral entry point of the C1 screw cause vertebral artery injury and occlude transverse foramen on the left side. Patient has a non-dominant side vertebral artery injury, so it's not a severe problem after the surgery. But if you occlude the vertebral artery in the dominant side, it can cause devastating complications. Another type of technical problem is here. It's like this. I mean, C1 instability is very easy to be rotated during the surgery. If you make an entry point or if you make a tap, if you place a screw, C1 arch usually distorts, rotated during the surgery. So if you make an entry point adequately and if you make a medial trajectory, but still it can cause a vertebral injury. So we have to be very careful during the C1 screw fixation because it is very easy to be disoriented. In terms of C1 screw fixations, we usually choose the inferior lateral mass over C1 posterior arch as an entry point. Here's a video clip for C1 screw fixations. It's a rheumatoid arthritis related C1 instability. I fixed C1 arch not to rotate it during the manipulations and make an entry point. Just below the C1 arch, and I made a notch just above the C1 entry point. Make room for the dissection of C2 nerve root and dissect the venous plexuses, and make an entry point just between C1 arch and inferior lateral mass. This is a typical type of C1 screw fixation procedures. You usually make an entry point in the posterior arch of the C1 arch, and also we can make an entry point just below the C1 arch. But there's several types of V3 segment anomaly. For example, persistent first intersegment artery, which is what course below the C1 arch. And there could be another type of V3 segment anomaly, is fenestration. Fenestration is one of the branch of the vertebrae artery goes below the Sian arch and join above the Sian arch. And last type of abnormal V3 segment anomaly is the early branch of the PICA. PICA branch is usually originated above the Sian arch, but this type of variation, PICA branch originated below the Sian arch. In these three type of variation, we cannot make an entry point below the Sian arch because it can damage the vertebral artery. So the instance of the V3 segment anomaly we reported around 5%. So it's not that uncommon. So we have to be very careful to prepare Sian screw fixation. In this type of variations, you can see this type of variation on CT scans. In the cases of V3 segment anomaly, there's a deep groove on inner surface of the ipsilateral spinal canal like this. So in the cases of right side fenestration of vertebral anomaly, there's a right side inner asymmetrical deep groove on the right side. And also in the cases of left side persistent type of V3 segment anomaly, there's an asymmetrical deep groove inside the Sian arch in the left side, like this. I show some cases. First case is a 42-year-old female patient. Typical type of Sian instability caused by the rheumatoid arthritis. There's the ADI was increased on flexion image. But interesting thing is that there's a only branch of PICA on the left side. In this type of anomaly, we cannot place the Sian screw below the Sian arch because if you damage the PICA branch below the Sian arch, it can damage the brainstem infarct or cellular impact. And 3D CT angiography. 3D angiography shows that there's a difference between two vertebral arteries. Right side, the course of vertebral artery is normal, but on the left side, the PICA branch originates below the Sian arch. So I choose the entry point in the Sian dorsal arch. First thing is dissect the Sian arch, and then I dissected the Sian arch below the Sian arch and above the Sian arch, and PICA branch below the Sian arch. I made an entry point in the dorsal arch of the C1 to avoid the vertebral artery injury and PICA branch injury. But if you have to choose a Sian dorsal arch as an entry point, you have to think about the thickness of the posterior arch is adequate in this patient because the Sian arch thickness is very variable. So there's a lot of literature about the thickness of the Sian arch, and then about 46% of the patient is not adequate for the Sian arch as an entry point. Another type of variation we have to think about to make an entry point at the Sian arch is posterior ponticulus. Posterior ponticulus is a thick bony spicle above the Sian arch. It's not a true thick lamina Sian arch. So if you make an entry point in the posterior ponticulus, you can damage the vertebral artery below this type of bony spicules. So if you want to choose Sian arch as an entry point for Sian screw fixation, we have to think about the thickness or this type of variations. Second case is another Sian instability, but the patient has a persistent type of Sian V3 segment anomaly on the left side. It is a vertebral artery course abnormally below the Sian arch. In those type of variation, you cannot choose an lateral mass as an entry point. So I choose the superior lateral mass as an entry point for this patient. This is a Sian arch, and I made an entry point over the Sian arch because there's no vertebral artery in this patient. So there's another thing is there's not so much venous plexus over the Sian arch, so it's not a difficult one to place a Sian arch over the Sian arch for this type of variations. After surgery, you can see the Sian screw located above the Sian arch, and 3D angiography shows that there's a big difference between both sides Sian screw fixations. Left side Sian screw located above the vertebral artery, and right side C1 screw is placed below the vertebral artery. Third case is congenital anomaly related C1 instability. Actually, patient has a vaginal invaginations. Patient has a clipper face syndrome and biped C1 arch. So patient has lots of kind of bony abnormality combined. Interesting thing is both sides of the vertebral artery is abnormal. Left side is a persistent type of vertebral artery, and right side is olive branch of Pica is located below the C1 arch. Angiography shows the left side of the vertebral artery is located below the C1 arch because patient has occipital assimilation. Actually, this is a C1 arch, not a occipital bone. So vertebral artery equals abnormal below the C1 arch on the left side, and right side there's an olive branch of Pica below the C1 arch. So we cannot place the screw like this. So I choose the transarticular type of screw on the left side, and C1 screw, and make an entry point at the posterior arch at the right side. Post-op X-ray shows left side screw is a transarticular type of screw, and right side is a C1 posterior arch entry point C1 screw. The first case is very similar. Patient has a clipper fail and occipital assimilation, and patient has C1 instability. So if patient has a bony abnormality around the corneal junction, you have to think about there could be a vertebral artery anomaly. CT angiography shows there's a persistent type of vertebral artery on the left side, and right side the vertebral artery is normal. So I choose skip the C1 screw fixation for this patient. So in the cases of V3 segment anomaly, you can have 5 different type of strategies. First thing is you can place a C1 screw at the C1 dorsal arch, and you can choose a spiral mass above the C1 arch as an entry point of C1 screw. And third technique is we can choose to avoid the vertebral injury. And also we can skip the level of fixation and extend the level of fixation up the cranium or downside. And also we can mobilize vertebral artery to avoid vertebral artery injury during the surgeries. But we cannot guarantee if it is a dominant side of vertebral artery mobilization itself can be risky for the patient. In the literature, V3 segment anomaly is very rare. V3 segment is abnormality article usually reported in the Asian population. So it's about 5% or up to the 13% in the literature. Another interesting finding is vertebral artery abnormality around the cranial vertebral junction is very rare in US populations, in Caucasian populations. So we analyze the real instance of risk factors of V3 segment anomaly who need posterior instrumentations. I analyzed 147 patients who underwent C1 posterior instrumentations and analyze the risk factors of the V3 segment anomaly. The real instance was about 7.5%, and around 36% of patients has a normal bony architectures, and 64% of the V3 segment anomaly is combined with congenital bony abnormalities. So the instance is quite different between normal population and patients who had congenital bony abnormalities. It's a very statistically significant. So interesting thing is if patients have a congenital bony abnormality around the cranial vertebral junctions, it could be a risk factor for V3 segment abnormalities. And rheumatoid arthritis was not a risk factor for V3 segment abnormalities. So if a patient have a congenital bony abnormality around the cranial vertebral junction, you have to think about there could be a high risk of with risk segmental anomaly. So we have to change the strategy of the surgery. Second thing is a C2 screw. There's 4 different type of C2 screw fixation. For example, C2 transarticular screw fixation, and you can choose a C2 pars screw. You can choose a C2 pedicle screw, and you can choose a laminar screw instead of pedicle screw, especially for the patient who has a high riding vertebral artery. Here's a video clips. I usually choose a pedicle screw for the C2 screw fixation because C2 pedicle screw is biomechanically very stable compared to another type of screw fixations. When you make an entry point in the superior medial quadrant of the C2 pars, you can identify the medial margin of the C2 pedicle. You can follow the medial margin of the C2 pedicle, and you can avoid the vertebral doing this type of construct. The problem is that there could be a high riding vertebral in some cases. But high riding vertebral artery is medially hooked vertebral artery in the C2 pedicle. So if you place a C2 pedicle screw in this type of variation, you can damage the vertebral artery. As you can see here, the pedicle diameter is quite different between normal population and the patients who have a high riding vertebral artery. In the normal population, you can place the transarticular screw or pedicle screw without any risk of the vertebral artery injury. But in the cases of high riding vertebral artery, you cannot place a transarticular screw or C2 pedicle screw. So this type of construct can damage the vertebral artery in the cases who have a high riding vertebral artery. Left side of CT scan is a high riding vertebral artery in normal bony architectures. But interesting thing is in the cases of rheumatoid arthritis, the pedicle width and height is very narrow because of the C2 joint mutilation, because of decreased size of the C2 pedicle. So there could be a high riding vertebral artery risk is very higher in the rheumatoid arthritis patients. Here's a case of opocervical spine deformity. I place a screw in the, I place a C2 pedicle screw in the C2 area, but patient complaining left side weakness 2 weeks later. I checked the MRI. The MRI shows a right side medullary impact, even though it's quite small, but patient has a severe degree of weakness on the left side. CT angiography shows a right side vertebral artery was occluded by the screw, even though it's not a dominant vertebral artery, but it can cause a severe degree of weakness after the surgery. The trajectory of the C2 pedicle screw is quite low, so it can damage the vertebral artery. There is a reason why patient complaining left side weakness by the brainstem impact. So in this situation, you'd better choose a laminar screw instead of pedicle screw, because if you use a laminar screw, it can reduce the risk of vertebral artery injury, even in the cases of a high riding vertebral artery. And another advantage is we don't need to fluoroscope doing the C2 laminar screw placement. Here's a video clip for the different strategy for the high riding vertebral artery injury. I placed pars screw on the right side, bilateral high riding vertebral artery, and also I placed laminar screw on the left side. So, but it can be very useful for the patient who have a high riding vertebral artery in the C2 V2 segment. This is a post-operative X-ray. I placed the left side pars screw. Pars screw is a short pedicle screw. The end point of the just behind the transverse foramen. So left-sided part screw and right-sided laminar screw. You can place the bilateral part screw, you can place the bilateral laminar screw, and you can place a hybrid type of construct for the high-riding vertebral artery injury cases. But in the cases if you want to choose a laminar screw, you have to check the preoperative CT scan, because laminar thickness is quite different from each patient. So some patients, we cannot place the 3.5 mm screw because laminar thickness is not good enough. Another thing is I'd like to show today is how can we assess the vertebral artery during the surgeries. So the 7th case is congenital anomaly cases. Patient has CRT instability, also occipital stimulation and critical failure syndromes. MRI shows there's a high degree of compression around the skull base because of the CRT instability and granulation behind the C2 dense process, like this. Patient has a bilateral persistent type of intersegmental artery, like this. So you cannot place the CR screw below the CR arch. But patient has a visual invagination, so I'd like to reduce the visual invagination by place the facet cage inside the center facet joint to reduce the to down migrate the C2 dense. So we have to manipulate vertebral artery. It is inevitable. So what the problem was how can I protect the vertebral artery, and how can I guarantee the vertebral artery blood flow is intact even after the surgery? So I placed a bilateral CR2 construct, and I placed a facet cage inside the CR2 facet joint. Even though I protected the vertebral artery as much as possible, I'd like to identify the vertebral artery flow is good enough after the surgery. So I used indocyanine green video angiography after the surgery. So I found the vertebral artery integrity is intact. It's very useful to use ICG during the surgery, especially for the cases who have a high risk of vertebral artery injury and vertebral junction surgery. And if you want to choose a cervical pedicrucial fixation, you have to be very careful to avoid vertebral artery, and also we have to evaluate the good enough after the surgery. But limitation is not a quantitative and functional study, so only thing you can see is vertebral artery integrity is good enough, but you cannot measure the blood flow is good enough or not. But it's very useful if you worry about vertebral artery injury, especially for the cases of vertebral artery abnormalities. So, summary is surgical strategy should be based on preoperative imaging study and thorough understanding of normal and abnormal anatomy is very important to avoid vertebral artery injury during the surgery. And careful operation planning is very essential. And treatment should be specific, even though surgical title is same. For example, CRT instability, we need to do a posterior CRT fixation and fusion, but each patient anatomy is very different. So we have to choose different type of CRT construct and different type of C2 screw placement. So we have to be very careful to decide what to do for each different type of patient. Successful outcome is a product of sufficient evaluation and appropriate decision and sound surgical technique. So do no harm is one of the main topics for the spine surgeon. Thank you.
Thank you, Jay, for an excellent, well-illustrated presentation. The illustrations were very clear. And I'm not a neurosurgeon, but it seemed to be very, very complete. It will be okay to get off the Hangout. Just click on the green arrow on the. There you go.
Okay.
There you go. Well, now you've been introduced to the technology of Hangouts and presenting presenting a case or presenting an idea. And I hope that you're part of the community in the future.
Mhm.
You know, we may have had an issue with sound a little bit, but you can listen to it and tell me if you like it. We're going to edit it. We're going to send it to you, and keep you in contact if we have any other events. Next Sunday, we have an event from Seoul, a spine conference from the Nori Hospital.
Okay, I heard about it.
Yeah, that you can come and watch if you want. We had it's all day. It's an all day. And Dr. Kim, I don't know if do you know Dr. Kim Hyung Kim?
Yeah, I know him.
Oh, okay. Well, it's his conference, and maybe you could sit on the panel with me and watch it. So, anyways, I appreciate the time and effort, and I'll be sending you the edited video soon.
Okay.
And I'll let you know about Sunday. I'll let you know information, send you a link to join us if you want.
I'm not sure I can attend the symposium or not, but I'd like to want to feedback for the presentation because I'm worrying about the sound because you mentioned about it.
Okay. Well.
So I'd like to review my
Well,
presentation.
you can take a look at it. I'll be glad to do it again. I'll be glad to do it anytime you're ready, if you don't like it. But okay, Jay. Thanks for your effort.
Okay, thank you very much. See you later.
Good night.
Good night.
Bye bye.